talk about goals today. Goals/expected outcomes. And I'm going to identify what I mean by that goals/expected outcomes. But we're going to talk about building on the problems that we already have written, and then we'll end up writing another nursing diagnosis all the way from the beginning to the goal expected outcome. Now, if you read your book in Potter and Perry, a goal is identified as a focus, a patient focus on what you want, what you as the nurse want to work on with that patient. Such as, if we were talking about comfort, the goal might be that your patient will be pain-free. Okay, that's a goal. An expected outcome is even more focused. An expected outcome is, again, patient-focused on what we want that patient to achieve, but it is timed and it is measurable. Okay, so for that same comfort problem, expected outcome would be something like the patient will verbalize pain of less than 3 on a 0 to 10 scale over a period of time, on my shift, over 6 hours, or whatever. See how it's more focused? Now, the problem is that I've talked to you guys about the difference. And in the first year, you guys are really going to write expected outcomes. Okay? Those real patient-focused, oriented, timed, and measurable. Those are what you're going to write. But we're going to call them all goals. So we kind of mess you up because we're saying the word goal, but you guys are actually writing expected outcomes. And it's just something that I live with you guys, and I get you used to it, and I tell you up front that you are writing expected outcomes, but faculty are calling them goals. Are you with me? Okay. When I give you test questions, I'll always say goal/expected outcome. Okay, and you always make sure they're timed, and you always make sure they're measurable. And since you're getting the test questions from me, I can tell you that right now, that they will always be expected outcomes that I want you to write. Okay? So that being said, let's look at what your first nursing diagnosis is that you guys have. Because everyone's a little bit different, so what do you guys have? Go ahead. That's your basic human need. What's the nursing diagnosis?
Mobility.
Okay, so mobility impaired, and I'm just going to write. I'm not going to write the whole thing out because you guys already have that written from the last week. So I'm just going to put mobility impaired, so we make sure we stay focused, and you guys have the whole problem all written out. Okay, what is our expected outcome going to be for our patient? Remember the things that we need: patient focused, timed, measurable. Give it a shot.
Client can comfortably become mobile within 2 weeks.
Okay, you're on the right track, but there's a couple of problems. Become mobile. What does become mobile mean to you?
How about do a range of motion then?
What's become mobile mean to you, Joan?
That would mean to get around on his own.
Okay, do you see where I'm coming from?
To specify. Walk down the hall, ambulate out of bed.
Okay, we're getting there. How about
Take it, Meredith.
how about we look at how far? How far is our gentleman walking now? If we look.
0.
Well, is he walking 0 feet?
No, he has a quad
If you
cane.
look at your cluster sheet, and how many feet is he walking? Okay. So let's look at, if our gentleman is walking 100 feet, what do we might want him to do?
Increase that.
Increase that. How much?
Another 50 feet to 100 feet, depending
Okay.
on his what he can handle, his activity tolerance.
Okay. So we're looking at maybe going up to 150 feet. Is that reasonable with everybody? Okay. Now the next thing that you said is that 2 weeks. Are we there for 2 weeks? No. We're there for a limited period of time. And since we're doing these care plans ourselves for you, you're doing them for your time on that unit, you can do one of two things. You can time it to on my shift, which is what the majority of nursing students do, or you can say over, the 7 hours, over 7 hours, because that's how long you're there. Know that when you go out there in the real world, though, and you're a nurse and you're doing the care plans, it's probably going to be more of an extended period of time that you're going to be doing them to, and you're not going to write on my shift. Okay? You're not going to do on my shift because you're writing the care plan for all the shifts. Okay, so right now you can do on my shift, or you can do 6 hours or 7 hours or however long you're in clinical. But when you get out in the world, don't write on my shift. Okay? Because it's for a group of nurses caring for your patient. Okay?
So for our 7 weeks of clinical, we're not going to always go back to the same site, or we are?
Yeah, you are.
We're going to have different patients.
Exactly, you're going to have different patients. Okay, so our goal is patient will, and what's our patient going to do? He's going to ambulate. And we decided on 150 feet on my shift. OMS is usually it's what we abbreviate on my shift here in the program. Or you could have done, instead of on my shift, over 7 hours. Whichever way you guys want to do it. You tend to do the on my shift. Okay? All right? That's the first one. That's done. What's the next nursing diagnosis that we have? I'm just going to put a line here. Okay, constipation. I remember that. Okay. What are we going to do for our expected outcome? What do we want our patient to do?
Go to the bathroom.
Yes, we want him to have a BM on our shift. You want him to have 1, 2, 3, 4? One would be okay? Do we want to have small, medium, large?
Medium would be good.
Okay, so let's write it. Patient. How are we going to write it? Patient will. How about move bowels? Times 1 medium on my shift. Okay? You could have written it a couple of different ways.
This may sound stupid, but what if what if you're working first and this person tends to be an evening person?
It's okay.
Okay, so if it doesn't happen, just rewrite it?
No. Oh, no.
Something you're aiming for, is that
Yes,
right? It
exactly.
doesn't necessarily have to happen.
Right, and if it doesn't, you guys do what's called a reflective journal after clinical, and you look at things like the goals that you wrote, and if those goals were achievable. Maybe that goal of walking 150 feet was just too lofty. It was too unreasonable when you actually got in there and took care of the patient that day. Or maybe it was, a terrible weather day, and your patient had arthritis. And the day that you ended up going in there, the weather was horrible, it was rainy, the arthritis was really kicking up, and you couldn't achieve that 150 feet. That's okay. Your patient might not have walked 25 feet that day. As long as when you get to that reflective journal, you identify what happened and why your patient wasn't able to meet that goal. Sometimes it's just that you overestimated when you were at home sitting there writing your plan. You just overestimated what your patient could do. Okay, and that's all right, as long as you identify it. If they didn't have a bowel movement, well, that's okay too. Okay, as long as you identify it. Okay, problem number 3. Okay. Okay, what's our patient will
Not have an incident of incontinence on my shift.
Okay, that's fine, and that's a perfect one. Although I like to state it in a positive instead of in a negative. Like a negative is patient will not be incontinent. I like to state it as a positive. Patient will remain continent. on my shift. It's just a positive. It's either way, it wouldn't be wrong. Patient will remain continent on my shift. Okay? Now, if you were taking care of this patient on the day shift in your extended care facility, would you have written up this nursing diagnosis? When's this problem? It's at night. So we wouldn't have written it for the daytime, right? But for our purposes, it's okay. I just want you to differentiate that it's a problem that's at night for the patient and not during the daytime. So therefore, it wouldn't really affect our care of him, and it probably wouldn't have been a problem that we'd have identified. But that's okay. All right? So now let's start another problem from the beginning until where we are now. We'll do an entire problem and see it from start to where we're at. So where do we want to go?
We just pick out a new basic case.
Yep. Maybe want to go, we can go oxygen, or we can go asepsis. You want to do asepsis first?
Yeah, that makes sense.
Yeah? Okay. So our basic human need is asepsis. Any subjective data? No? No. Okay. What's our objective data?
Skin breakdown?
Okay, skin breakdown. Now, let's talk about where the skin breakdown is. Let's do this as if you were in clinical and you were going to clinical the next day and you were doing this yourself. Where is the skin breakdown? Exactly.
Kind of tiny.
Okay, sacrum. Sacral. Is it an open area or is it a redness?
Redness.
Okay, so it's red. Okay. Where else?
Left forearm.
What do we have on the left forearm?
Tegadan.
Pardon?
The Tegadan dressing.
Okay, so we've got open areas, right? We've got tears. Right? Where else do we have it? I'm going to put our Tegaderm dressing right here.
Elbows.
Pardon?
Left elbows.
Okay, left elbows. What do we have in left elbows?
Redness.
All right, where else? Anywhere? Is that it? Does it say anything about dressings or anything like that? No? Okay, so what's causing all the skin breakdown? What's our right-sided weakness and our CVA? So I think that, remember that was kind of, it was pretty much across the board that was affecting all of our this patient's basic human needs. So I think we need to put that one in there.
But the sacral area could be due to the incontinence at night or occasional incontinence.
Yeah, it's probably a combination of, so maybe we need to put the incontinence at night down here? That was a terrible A. Okay, anything else? We can add if we need to. All right, so let's go to our cards and look and see what we might want to look up. Give it a shot. Need some help?
Skin integrity repaired or impaired,
Uh-huh.
461.
Okay. Skin integrity impaired, 461. Where else?
Skin integrity risk for impaired, 465.
Risk for skin Okay? Can I add one to it? Because you see it happening frequently, and this one this tissue integrity impaired is kind of like an umbrella one, and it takes a lot into consideration. So I like to have everybody look at that one, even though it might not apply to this particular problem. You see it used a lot as almost a blanket for a bunch. And I don't know what page that's on, do you guys?
533.
Anything else?
Would you include the
What we've done,
urinary incontinence?
we've done the problem already for urinary incontinence. So we don't really have to do that one again. Anyone else see anything? That might be it. I think that's probably good enough. If anyone else sees anything? No? Okay, so let's look at skin integrity impaired on 461, and if you could just read that.
The definition.
Mm-hmm.
Altered epidermis or dermis.
Mhm.
The integumentary system is the largest multifunctional organ in the body.
Okay. And risk for 465?
At risk for skin being adversely altered.
And tissue integrity.
Damage to mucous membrane, corneal, integumentary, or subcutaneous tissues.
Okay, so we've got skin integrity is an altered epidermis and dermis. Risk for is at risk for skin skin something altered. I don't remember what that. And tissue integrity impaired was damage to mucous membrane, subcu, and integumentary tissues. Is there one we can get rid of right away?
It's on the top. It's not been altered yet.
Well, do we have open areas?
Oh, okay, all right, that's right, yep.
We do. So we can't get rid of that one. What about risk for?
Yes, we can.
If you guys are ever stuck on whether it's an actual problem or a risk for, ask yourself, what doesn't a risk for nursing diagnosis have?
Signs and
Signs and
symptoms.
symptoms.
It doesn't, you're absolutely right, it doesn't have signs and symptoms. So if you get to, say, you're thinking it's a risk for skin integrity impaired, and you get down to the S, the signs and symptoms, you've got the P, you've got the E, you get down to the S, and you say to myself, okay, what are the signs and symptoms? And you can come up with signs and symptoms, you don't have a risk for. Because remember, risk for doesn't have the signs and symptoms. So because you have skin breakdown, you've got the signs and symptoms, it's not a risk for.
So you can get rid of that one.
Get rid of it. Okay. Now that leaves us with the skin integrity impaired and tissue integrity impaired. Right? Let's just look at some of the related to factors for tissue integrity impaired and see. Just read them.
Altered circulation, nutritional deficit excess, metabolic endocrine dysfunction, fluid deficit excess, knowledge deficit, impaired physical mobility, irritants, chemical, including body excretions, secretions, medications, radiation, including therapeutic radiation, thermal, temperature extremes, mechanical, e.g. pressure, shear, friction, surgery, knowledge deficit, infection.
So we have a couple of those things, don't we, that are under tissue integrity? We have a few. Okay? So now let's look at skin integrity on 461. Because remember, if you can't figure out which one it is, go to your next step, which is going to be your related factors, and see which one fits the best. Okay, you want me to read them? Sure. Related factors for skin integrity. Hyperthermia, hypothermia, chemical substance, physical immobilization, we've got that. Humidity, moisture, we have that?
Excretion, secretions, yeah.
What about at
A
night?
little bit.
Okay, so we've got that. We've got 2. Altered fluid status, mechanical factors. We have the shearing, the pressure. We have that, don't we? How about extremes in age?
He's 70.
He's 75. You know, extremes in age is kind of hard to define. I mean, extreme in age to you might be 90. Extreme in age to me might be 50. You know.
These days that doesn't seem extreme so much.
Right, 75 doesn't seem extreme to me. But, I mean, you probably can make a case because I think that's a real subjective call, whether that's extreme or not. To me, extreme is like 100 or 90. But let's go on. Altered nutritional state. Skeletal prominences. We don't know if we have that. Altered circulation, developmental factors, immunological factors, psychogenic. We don't have those. But we do have immobilization, we do have moisture, and we do have mechanical, and we could make a case probably for age. So I think, what do you guys think? Which way should we go? I think that if we're listing them, we probably have more related factors if we look at skin. But if you had taken the tissue route, I don't think that you would have been wrong. And I don't think I would have been able to say to you that that is not an appropriate problem. I think you could make a good case for it, and that's fine. Okay? Of the 2, which one is your better? Skin. Because it's got more related factors. You're right, it's more focused. Okay, so let's write it out. P, skin, integrity, impaired. E, related to. Now, see if I get them all. Physical immobilization, age, moisture, what else was there? Mechanical, the shear. Anything else? Is that all? There's a lot of them. 1, 2, 3. There was 4, wasn't there? Was there any more?
Should you put down the ones that don't pertain? Like, because hypothermia, hyper or hypothermia really aren't his.
We don't have evidence, though, do we?
No, right.
I mean, if he had a temperature of 102, then yes, definitely. But I think we were at like 99. Wasn't it like 99 or something like that?
What about developmental factors? Because he has the right side weaknesses.
A developmental factor, I would think, would be more of a child, a kind of a growth and development. Okay, so now what are our signs and symptoms? What do we have? We have the CVA. Or actually, why don't we put the right-sided weakness? Because that's our physical immobilization. We're 75 years old. We have the incontinence at night, right? And I think the mechanical shear, we can just leave at that because that has to do with our right-sided weakness and not being able to move. So I think that's identified. Right? Okay. So what's the expected outcome going to be? Patient will
You say something like show less redness on his sacral area on my shift or by the end of my shift.
You could probably write 2 different goals and be very appropriate with them. Or we could kind of combine them, like in patient will not have increase in breakdown on my shift, just write skin breakdown on my shift. You could really get fancy with this and put dimensions and have, you know, a decrease in dimensions. I don't know that that's appropriate to do. I mean, you probably, when we measure it and everything, you might want to write one after that, but I think that no increase in breakdown is fine. Okay? We'll have no further increase in skin breakdown on my shift. Okay, so I wrote, patient will have no further increase in skin breakdown on my shift. Okay? Next week we'll do the interventions to that one. Do you want to do one more? We have a few minutes. You guys have like a blank care plan? Yeah, you should. Can we do O2? That'd be okay? Okay. What's our data? Do we have any subjective?
Smoking.
Yeah, that's subjective. Smoked 2 packs per day times, what, 20 years or so? Okay, what's our objective data?
You said objective?
Mhm.
2 liters, nasal cannula.
Yeah. O2, 2 liters, nasal cannula. Anything else? What does he have in his history
Angio.
that has to do with our O2?
Pneumonia.
Aspiration pneumonia.
Yeah, aspiration pneumonia. History of aspiration pneumonia. Is he on some precautions to prevent further aspiration? He's on aspiration precautions? He had a CVA. I think that should go in there. You'll see why later. It's what's causing our overall problem, so our O2 problem, so I think we need to have, I think it's relevant. Because that really does work across the board, affecting all the basic human needs. Okay, so let's look at our card and see what diagnosis we might come up with.
Aspiration risk for
Okay? What page is that on?
6.
86, aspiration risk for. What else? Anything?
Breathing pattern.
Breathing pattern? What page?
17 and 21.
Okay, breathing pattern ineffective. Where else?
Would gas exchange impaired?
Yeah, we don't know what gas exchange impaired means.
Is the ventilation impaired?
We don't know what that means. So I don't think that those are unreasonable. So gas exchange is on what page?
256.
256. And ventilation is on what?
581.
Okay. Anything else? That's a pretty good list. Yeah, go ahead. Yeah,
At
80s.
risk for entry of gastrointestinal secretions, oropharyngeal secretions, or exogenous through solids or fluids into tracheobronchial passages due to dysfunction or absence of normal protective mechanisms.
Bottom line is GI secretions going into lungs. That's what basically risk for. Okay, what about breathing pattern ineffective? 117.
Inspiration and or expiration that does not provide adequate ventilation.
Okay, inspiration, expiration without ventilation. Gas exchange 256.
Excess or deficit in oxygenation and or carbon dioxide elimination at the alveoli capillary membrane.
Okay, increase or decrease in O2 CO2 exchange. I'll explain it. And ventilation impaired, 581.
Decreased energy reserves results in an individual's inability to maintain breathing adequate to support life.
Okay, inadequate ventilation, basically, because you have no energy to sustain life. Something we want to take out?
Risk for.
Why we want to take out risk for?
Because he already has the signs and symptoms already.
Yeah, he's already had it. He's already got it. You're absolutely right. So does everyone agree we can get rid of that? It's gone if you don't. Okay, what next? What doesn't belong? Remember our squares, 3 squares in a circle? What doesn't belong?
Ventilation impaired.
Right, do we have an energy problem?
No.
Doesn't belong. But don't feel bad if you're the one who put that out there because we wouldn't know until we looked at it. Okay, breathing pattern ineffective? Inspiration, expiration without ventilation? We don't have like an asthma or chronic. You'll see that. Okay, now, this leaves us with a little predicament. Let's look at the related to factors for this. Let me explain what it is. Here's your lung, here's your alveoli, here's your capillary. What you've got here is something that's in between that's stopping O2 from going out and CO2 from coming back in, such as congestive heart failure, extra fluid in the lungs, it's accumulating there. Pneumonia, mucus, it's accumulating there. Chronic changes, it's stiffening those alveoli. Something is stopping O2 and CO2 from exchanging. Okay? So, look at the related factors and just read them off and let's see if it fits.
Ventilation perfusion imbalance, as in the following: altered blood flow, pulmonary embolus, increased vascular resistance, vasospasm, heart failure, hypovolemic shock.
Do we have something that's stopping blood from going to our alveoli? Like a clot. Do we have a clot in our lung? Something that's inhibiting blood from flowing into that capillary. Do we have that? No. Okay, so move on.
Alveolar, capillary, membrane changes. Example: acute respiratory distress syndrome, chronic conditions such as restrictive obstructive lung disease, pneumoconiosis, you can help me out with that. Pneumoconiosis, respiratory depressant drugs, brain injury, asbestosis, silicosis.
Do we have any of that? We have none of that, right? We don't know if we've got, I mean, chances are he probably has some chronic lungs with,
Smoking.
but we don't have documentation of that, so we can't say that that's our problem. Okay,
Altered oxygen supply, like altitude sickness. No.
okay.
Altered oxygen carrying capacity of blood, like sickle cell or other anemia, carbon monoxide poisoning.
Do we have any of that?
No.
So is that going to be our problem, our diagnosis? So we're in a predicament because now we've got to go back to our card and look at something else that might fit because we know now that it's not this gas exchange. Okay? It happens. Here, I'll look at this card and see if I can find anything. See, I already have the answer. Any idea? I see a couple potentials.
What about swallowing impaired?
Let's look at it. Swallowing impaired. What page is that on?
510.
Can we look at also, there's another one. Look under your O2. Do you have airway clearance?
Ineffective.
You maybe want to look at that one? Sure? Yes? Anything else? What page is airway clearance on?
69.
Okay, I just don't have a card with numbers on it, sorry. I stole it. Okay, is that it, or you want to look at something else? No? Yes? Maybe?
Let's look there first.
Okay, that's fine, 510. That's fine. For swallowing.
Abnormal functioning of the swallowing mechanism associated with deficits in oral, pharyngeal, or esophageal structure or function.
Okay, airway clearance 69.
Inability to clear secretions or obstructions from the respiratory
Okay. Do we want to take one out? Can we take one out?
Yes.
Which one?
Swallowing impaired.
Really?
Yes, that's for pneumonia.
Due to the CVA probably, right?
Let's look at the related factors of airway clearance and see what we come up with for airway clearance on 69. Okay, smoking, secondhand smokes, smoke inhalation. But is that going to cause us to clear our airway? He's not smoking now, is guess what I'm saying to you. Retained secretions in the bronchi. Does he have that? Chronic obstructive pulmonary disease, asthma, allergic airways. Does he have any of that stuff? No. So can we have that problem?
No.
No, but let's look at swallowing. Maybe that's our problem. Page 510. I'm getting rid of airway.
Upper airway anomaly, mechanical obstruction, example edema, tracheotomy, tube tumor, history of tube feeding, neuromuscular impairment,
Do we have that?
decreased strength or excursion of muscle involvement in mastication, yeah, right-sided weakness,
Yep.
perceptual impairment, facial paralysis, conditions with significant hypertonia, cranial nerve involvement, right-sided weakness again.
Do we have facial paralysis?
Right-sided weakness? It
Yeah.
didn't say it-
Probably.
Partial.
Yeah, if he's had aspiration, he probably does. Pocketing. Anything else?
Respiratory disorders, congenital heart disease, behavioral feeding problems, self-injurious behavior, failure to thrive, or protein energy malnutrition. Neurological problems, external internal traumas, acquired atomic defects, nasal or nasopharyngeal cavity defects.
Don't we have that? Don't we have something going on
Yeah.
that's paralyzed, like a vocal cord that's paralyzed open from that CVA?
Oral cavity or oral pharyngeal.
Pharyngeal, yeah.
Thank you. Anomalies, upper airway, laryngeal, I can't read anymore.
That's okay. I just dropped my chalk, so forget it. Okay. All right. So, gastroesophageal reflux, we don't have. And premature infants, we're not a premature infant. Okay. We don't have a traumatic brain injury. Okay. So, can we safely say this is it?
Yeah.
Okay. So, our problem is, or our patient's problem, is swallowing impaired. Our E, our related to, is what? That neuromuscular impairment. What else was there?
Would you put the CVA there?
No, because that's that's one of our signs. Here, why don't I read it while you guys write, just to.
Hypotonia cranial nerve.
Yeah.
No.
Let's see. Neuromuscular impairment. We've got. We've got the laryngeal anomaly, I guess we could say, because we've got that vocal cord. We also had mechanical obstruction. No, we don't have that. We have that facial paralysis, but that goes with our neuromuscular. I guess that's it, isn't it? There was like 3 or 4 things. That looks good. That gives us enough. And what are our signs and symptoms? Our S, as evidenced by what? What has he had?
Aspiration pneumonia.
Yeah, aspiration pneumonia and CVA. So we've justified our related to. Now the easy part in this was torture, but our easy part is our expected outcome. Patient will, what?
Patient will not aspirate.
Excellent. You got to time it though.
My shift.
Yes. Patient will not exhibit symptoms of aspiration on my shift. Now this gets tricky. The way that I wrote it right here, I did that on purpose because that gets tricky. Because what isn't it? It's not measurable enough. Okay? Exhibit symptoms. I would look at that if you guys had written that, and I would
have to
say,
look up aspiration symptoms.
right, you would have to, if you wrote it as this is right now, you would have to write all of those symptoms to make it measurable. So if you write it, though, a little bit easier even than writing it that way, because some students will do that and then do as evidenced by and then have a whole list. Patient will not aspirate on my shift. Easier? Okay? All right, let me give you a few tips. At this level in 101, write one expected outcome, right? Don't write 2 expected outcomes. Don't write 3. Just write 1. You guys what happens is you tend to get into trouble the more you write. And you do really good on that first one. It's well thought out and it's beautiful. And you'll have interventions for that one. And then you'll say, oh, okay, let me do another one. And either that next one doesn't have any interventions, or it doesn't relate to what our basic human need and our problem, the nursing diagnosis, is. So save yourself some grief. At this level, in this year, until you get real comfortable doing these, only write 1 expected outcome. And then the interventions to meet that. Okay? See how it's all flowing? We've got everything lines up. Everything flows from our basic human need right on over. It's all related to each other. I'm not talking about our diet over here and objectives. I'm not bringing our diet into this. It's enough to say that we've had a history of aspiration pneumonia. We're going to address all of that in our interventions. It's going to flow right across, and that's what's really important. I don't have any data in here that's not related to each other. All right? Really important to just remember that. Make sure it flows all together. Make sure that you're not talking about O2 and have all of your objective data or your data in there about skin. Okay, make sure that it stays flowing through. When we do interventions next week, we're not going to do interventions about skin when we're talking about swallowing. All right? That's it. Any questions? Nope. Have a good day.
Thank you.